No.
Good morning, everyone. We'll start the class soon. Myself, Dr. Ronit Roy from MR Bangalore Hospital. The topic for today's class is cystic hygroma, which is a seminar will be presented by Dr. Shubham Kumar from CNMCH. And the class will be taken by Dr. Shukumar Maiti sir and Professor Shukumar Maiti sir and Professor Makunlal Shah. We'll start the class soon as Shubham joins. Dr. Shubham has joined.
Yeah.
Dr. Shubham, are you there?
Shubham has joined. Yes. Shubham, you unmute and share your screen.
Shubham, you can start now.
Yes, we can see your screen. Shubham, please start.
Yes, sir. Sir, good morning, everyone. Today, I'll be presenting a case of cystic hygroma. Sir, it's not going back. Yes. My patient, Mr. ABC, a 1-year-old male, presented with chief complaint of swelling in the neck for 4 days. History of present illness, as stated by mother of the patient, he was apparently well 4 days ago when he developed swelling in the left side of neck, which was of sudden onset and rapidly increasing in size below the jaw. It was not associated with pain. There was no history suggestive of fever, cough, or respiratory distress. There was no history suggestive of similar illness in past, or no history of any surgery or previous hospitalization. Bladder and bowel habits were normal, and he is immunized as per national immunization schedule. There is no history of similar illness in family, or no history suggestive of any congenital anomaly in family. Summary: Mr. ABC, 1-year-old male, presented with complaint of swelling over left side of neck below jaw, which was of sudden onset and rapidly progressive. It was not associated with pain, fever, or respiratory distress. There was no history of eventful antenatal or postnatal period. He was immunized as per NIS. On examination, patient was conscious, alert. There was no pallor, icterus, clubbing, cyanosis, or palpable lymphadenopathy. Pulse rate was 90 per minute regular. BP was 82/54. mmHg. Respiratory rate was 18 per minute. Weight was 12 kg. On inspection, single swelling of almost 6 centimeter by 4 centimeter size over the left submandibular region, extending from midline to angle of mandible, with smooth surface, round margin, and it was non-pulsatile with normal overlying skin. It was not moving with degradation. On palpation, swelling was non-tender. Temperature of adjacent area was normal. Spectral findings were corroborated. It was 6 centimeter by 4 centimeter in size, soft in consistency, fluctuant. It was brilliantly transluminant and non-reducible. No abnormality detected on systemic examination. Summary: there is single swelling over the left submandibular region, which was of 6 centimeter by 4 centimeter in size, with smooth surface, round margin, soft in consistency, fluctuant, and transluminant. It was slightly compressible and non-reducible, and overlying skin appeared normal. The other part of neck appeared normal.
So what's your provisional diagnosis?
Sir, my provisional diagnosis is case of cystic hygroma over left submandibular region.
Go back to history. Yes, Dr. Maiti.
Yes, yes. Shivam, you have mentioned the history, almost everything which pertinent to this swelling. Past history you have mentioned. There is nothing significant in the past history. What to expect in the past history?
Yes, sir.
Illness in the past. By that similar illness in the past, what are the things you expect in the history?
Sir, there.
You are not audible. You are not audible. Shivam. Shubham.
Shubham, please unmute yourself.
Shubham.
Yes, sir.
Now you are
Yeah.
audible. What do you expect in the similar? What do you like to mean by similar illness in the past? Your provisional diagnosis is cystic hygroma. Do you expect that cystic hygroma will appear and disappear?
No, sir.
So what you should ask in the exam? What you are actually want to know? Any illness in the past, in what form?
Was there any eventful delivery or not, sir?
Rather, you can mention here because it is in relation to the left submandibular region. There are lymph nodes, there are salivary glands. So you can write in the history, there is no history suggestive of any inflammatory swelling. There is no history suggestive of any inflammation in that region in the past, in the last 1 year. Okay. Okay.
Yes, sir.
So no history of, yes.
Yes, Dr. Maiti. History of present illness, is it common history that a cystic hygroma grows so rapidly for 4 days? He said 4 days and there is sudden onset and rapid increase. Is it the typical history of cystic hygroma? Shubham?
Actually, sir, it is 4 days too less, sir. It actually progresses over some weeks.
So
Yeah, often it is a finding at birth. Often it is finding at birth. So it may be that the swelling was there in the neck. And second thing is, you said that he's a 1-year-old child. And you said his body weight is 12 kg. Do you expect 1-year-old child to be 12 kg weight?
No, sir.
And if there is swelling of 6 centimeter in a 1-year-old child, this swelling should occupy the whole of one side of neck. 6 centimeter is a very large swelling. So it cannot be confined to the submandibular region. And this swelling of this size can cause other symptoms like you should ask from the mother whether he is eating normally, whether he difficulty in swallowing. Okay.
There was no such history.
That's what I'm saying. Your history of Pathogenesis should cover a little more. The cystic hygroma can occur in other sites also. So whether he's got any swelling in other sites of the body. So these are the other information should give. Okay, Dr. Maiti, please.
So you have rightly mentioned it is not associated with pain. When it will be associated with pain, does it usually associate with pain?
Sir, if there is secondary to infection in this case, sir, or there is other, if there is other diagnosis like lymphadenitis or any inflammatory, if there is abscess, then it will be associated with pain.
So there may not be any acute onset of swelling. As you have mentioned, in last 4 days, it has rapidly increased. How a cystic hygroma swelling can increase very rapidly within 4 days? It is possible. It is not impossible. A cystic hygroma was a insignificant swelling initially, and it was not noted by the parents, but within last 4 days, it becomes significant in size. How it can happen? It's not difficult, you know it, I know. When a cystic hygroma increases rapidly.
Sir, if there is further,
somehow if there is hemorrhage within the cystic hygroma. Suppose there is a vessel on the wall and that opens and there is blood rapid increase, or there is inflammation. If there is inflammation, then it may increase suddenly. Okay.
Yeah. In that case, other symptoms will also appear. Patient will have pain, patient will have other compressive symptoms. Okay, suddenly the swelling has gone to 6 centimeter, can cause compression of the underlying structures also.
So next slide, come to the next slide. So no history of any surgery and previous hospitalization. So how this no history of any surgery or previous hospitalization is related to this swelling? How you can corroborate?
Sir, it might be that the patient has, if patient has, as cystic hygroma is, it may be recurrent. So if there is any previous, if the patient has undergone the surgery for the same and it has recurred, then this history might be significant.
Okay, next one. So
what is the reason for cystic becoming recurrent? You said it may recur. Why is cystic hygroma may recur?
Sir, because if during surgical procedure, if we have not completely excised the cyst wall, then it may recur.
Yeah.
Okay, next slide. No history of severe illness in the family. Is it possible that sometimes it is genetically related?
Yes, sir.
It is always sporadic, or in some cases there may be hereditary predisposition?
Sir, it may be hereditary, sir.
In few percentage of cases, 20 to 30%, it may be hereditary. There may be genetic relations. So no history of congenital anomalies in the family. Okay, next slide. So you're immunized. Okay, next one. So coming to the examination part, that is very important. No history of icterus, clubbing, cyanosis, palpable lymphadenopathy. So lymphadenopathy is usually associated with cystic hygroma?
No, sir, usually not associated.
Not associated. Okay, weight. Okay, 12 kg. It should be little less until unless there is obesity associated.
Yeah, 1 year boy, 12 kg is very unusual.
It will be around 9 to 10. Okay, 9 within 8 to 10. Okay, but 12 kg until unless there is some other abnormality, it appears little high. Next one. Single swelling, 4 centimeter, 6, as Professor Saha has rightly mentioned, that this 6 centimeter by 4 centimeter will not cover only the left submandibular region. That will be more extensive to occupy the other regions. So actually, I am going little bit away from these two classification. So you see this swelling is situated in the left submandibular region. So is there any significance of the position of the swelling in relation to the neck, in relation to the clinical features?
Sir, definitely, sir. If there,
How?
the position of swelling will be causing the pressure symptom.
If the,
If present, sir, if there is if it is present in the anterior part, and it will early develop pressure symptoms. Sir. Patient will be having respiratory distress.
so if the swelling is in the infrahyoid region, okay, or in the supraclavicular region, in the posterior triangle, the complications are less. If it is in the submandibular region or in the suprahyoid region, in the unilateral side, the complication will be little more higher. But if it is a bilateral submandibular swelling, the complication will be further higher. Okay. So if it involves all the components of both the sides of the neck, involving both the suprahyoid and the infrahyoid region, the complication is extensively high. That may be around 100%. If it involves both the sides of the neck, including the suprahyoid region. Okay. So,
Yes,
okay. So middle languable, the smooth surface, round margin. So you have mentioned round margin. Can you palpate the margin of cystic hygroma?
sir. So it as a whole appeared round, sir.
So it appears round, but when you are mentioning the margin, then you should be specific. Most of the time, the margins are impalpable until and unless it is a unilocular cyst. If it is a multilocular cystic hygroma, at the periphery, the cysts are so small, and most of the time it infiltrates into surrounding tissue. You cannot well define the margin. So rather you should mention always ill-defined. Most of the time you see that it always blends imperceptibly with the surrounding tissue. Until and unless it is localized unilocular cystic swelling, then it cannot be, the margin cannot be well defined. Okay. So swelling is tender, is non-tender. Temperature of the adjacent area was normal. Inspectory findings were corroborated. It was soft inconsistency, fluctuant, and you have rightly mentioned that it is brilliantly translucent. Any cystic swelling which is present since birth and brilliantly translucent is always cystic hygroma. Okay. If it is present since birth, it is always cystic hygroma. Or even in this age, if it is a brilliantly translucent, it is cystic hygroma. Is it always non-reducible?
No, sir. It may be partially reducible.
So how it can be reducible? Because there are multiple cysts. Some cyst enters into the adjacent tissues and there may be intercommunication. So if you press the superficial part, the fluid will pass to the deeper part. Okay. So there may be apparent disappearance or little reduction in the size of the swelling, but the total size of the cyst content is same. Okay. So you have mentioned no abnormality detected on systemic examination. Before that, you left some examination. What you should do after completing the neck examination and the other peripheral parts, one region
in the neck, Dr. Maiti, he should also mention the relation of the swelling to the sternomastoid and the trapezius.
Yes.
Because you see, the swelling of these dimension is not only in the submandibular region, it is extended to the other part of the neck. So swelling may be deep to the sternocleidomastoid.
How to suppose it is the left side? So how to examine the relation of the swelling relation to the sternomastoid? Most of the time, it is superficial or deep to the sternomastoid. Major portion of the swelling remains superficial or deep to the
superficial, sir. Major portion remains superficial.
So how to test that?
Sir, I'll turn the neck. No, turn the chin to the opposite side and I'll tilt the head to the same side.
Okay.
So this sternomastoid will be strong.
Suppose if it is a bilateral cystic hygroma in the upper part of the neck, how will you test? If it is a bilateral swelling, how you can make the sternomastoid of both the sides taut?
Sir, will take the head, will make
Chin,
take
chin,
sir,
chin, chin area.
chin forwards, sir. Will take the chin forward, so it will both
You just
the
show on your,
sternum
you
will
just show it on your face. How to do the test for bilateral?
like this, sir.
You should place your palm below the chin and ask the patient to press it down.
Lean forward.
Okay,
Oh.
only then both the sternum will be taut. Okay, so anything else in the neck other than examination lymph node?
If not, sir, any other, sir, I look for any other congenital anomaly.
You can also look for the position of the larynx and trachea. It is a very big swelling. As you have mentioned, the swelling is significantly big. So you should look for whether the Adam's apple or the laryngeal prominence is in the midline or deviated to the right side or not. Okay.
Yes, sir.
And then any nerve examination?
Okay.
Usually
Sir,
in the preoperative period, no nerve is affected. In the preoperative period, until unless it is complicated by injury. Which nerve may be affected in this swelling?
Sir, glossopharyngeal nerve or hypoglossal
Closely
nerve.
related, which nerve will be closely related? So at operation, you should be very careful to preserve those
Sir,
nerves.
spinal accessory nerve.
Spinal accessory, it is deeply situated more posteriorly, but the cervical branch of the facial nerve, you see left facial nerve, which is related more superficially, cervical branch of the facial nerve, marginal mandibular branch of the facial nerve, because the course of the nerve is close to this part. Okay, preoperatively, those nerves will not be affected, but you should document it so that preoperative and postoperative period, what is the status? Okay, so leaving the neck, what other region you must examine for this particular patient? But you have not included that examination.
Sir, in
Oral cavity. Oral cavity.
oral cavity. Oral
Okay.
cavity.
So many cases you will find there may be associated lesion inside the oral cavity. That may be either in the floor of the mouth or inner aspect of the cheek or the tongue itself. Okay, so those things must be examined, and better always you also do the indirect laryngoscopy to exclude any lesion in the larynx. Okay, so those things must be done. So next, anything in relation to the palpation? So you have examined the other region. What are the other regions? Not only the systemic examination, you to examine the other parts of the body. What are the other parts of the body you must examine?
Sir,
Where cystic hygroma may happen. Other important sites in the body where cystic hygroma may happen
What
also.
will happen?
sir, it may occur in axilla or in groin.
Yes. Axilla, groin, mediastinum you cannot see externally. Also the back of the neck you must examine. Okay, back of the neck or the back itself. So those regions, not only that, even abdominal wall, you should examine and ask the parents whether there is any other swelling anywhere in the body.
Yes.
On the surface skin, what was the color of the skin? It is normal?
Sir, color becomes, sir, pinkish.
Pinkish, is it? If it is a very large swelling, so what is the usual color?
Skin becomes thin, sir.
Thin. Skin is thin, and a skin is thin with fluid, clear fluid. Is the fluid clear or turbid?
No, clear.
Crystal, almost crystal clear in an uncomplicated cystic hygroma. So how the swelling looks? In many cases, if the skin is very thin and the swelling is large, it is little bluish. Bluish. So can it be a plunging granula? If it is a bluish in color, can it be a plunging granula?
Sir, granula usually is present inside the oral cavity.
The granula is bluish or that is also colorless? Granula contains what type of fluid? The granula?
Is granula transluminant?
It's a transluminant.
And
Yes.
is transluminant? So what is the color?
It also contains the color exactly.
Have you seen any case of ranula?
No.
No. It is also bluish. That the color of hemangioma and ranula differs. A hemangioma in the floor of the mouth or the under surface of the tongue is deep bluish black as the color of a vein. Okay, but in ranula, the color is bluish, though it contains clear fluid. Do you believe that a fluid, a cyst containing clear fluid will be bluish? Do you believe?
Sir,
Normally, water
it
has
is
no color, but if it contains, if the ranula contains clear fluid, it also looks bluish. Why?
sir, because of the overlying covering.
Overlying mucous membrane with the
Mucous
vessels.
membrane.
Is very thin.
Yes, sir.
It is traced and thin. So when a overlying membrane is traced and thin, and if it contains the clear fluid, it may looks little bluish. And that happens in case of ranula as well as a cystic hygroma, which is large with thin skin. Okay, in the skin of cystic hygroma, sometimes you may find some other feature that is not so common. You may find, particularly in case of cystic hygroma, when it is present at other sites other than neck. On the surface skin, you may find other findings. That I'm just telling, if you look in a case of hemangioma, when it is a mixed hemangioma, below there is cavernous hemangioma, on the surface there may be strawberry or the capillary hemangioma. Same thing may happen in case of lymphangioma, that is cystic hygroma. In some cases, on the surface, you may find small, very small cystic swelling which are conglomerated together. Okay, just like toad skin, but the lesions are cystic, containing clear fluid. So that may be a feature, and by that you can say whether it is a lymphangioma or hemangioma. In hemangioma, that will contain blood. In lymphangioma, that will contain cystic fluid. And that is a very characteristic. Once you find it, you can definitely say it is lymphangioma. Okay.
Yes.
Then what is hydrocele of the neck?
Sir, cystic hygroma is also known as hydrocele of the neck.
No, not all cases. Not all cystic hygromas are hydrocele of the neck. Not all cases of cystic hygroma are called the
Sir,
hydrocele of the neck.
when it is unilocular.
Yes,
Sir, when
you're right. You're right. So if it is unilocular with well-defined rounded margin, then we call it hydrocele of the neck. Okay. So in relation, what is hydrocele of canal of neck? Neck and neck. What is hydrocele of canal of neck? Canal of
Where is
neck.
the canal of neck? Canal of neck is located where? In female patient?
Sir, in the femoral ring.
Not femoral ring,
canal.
actually.
In the inguinal canal. If the processus vaginalis remain patent in the inguinal canal of the female patient, and if a hydrocele develops in the processus vaginalis in a female patient in the inguinal canal, we call it hydrocele of the canal of neck. Okay. Okay. Then, Bahular, you ask few questions.
Yeah. What is the genesis? Why does the cystic hygroma happens at birth or at 1 year of age? So
Sir,
how does hygroma?
Because primitive lymph jugular lymph sac, when it fails to communicate with jugular vessels.
What happens normally? What is the normal development of lymphatic channels in the body? There is lymphatic in the lower limb, trunk, and the neck. So what happened to these lymphatics?
Sir, they normally
Maybe of
develop
what?
and communicates with the adjacent. They sir, ultimately they train in the circulatory system.
Yes.
In this case,
So
it fails to communicate and
what lymphatic sac appear in the neck? What are they called as?
the jugular lymphatic sac.
Yes, jugular lymphatic sac. What happened on the left side? What happened on the right side?
Exactly. I don't know. Difference.
On the left side, this neck lymphatic joins to the thoracic duct and drains into the junction of left subclavian and interjugular vein.
And yes,
Okay. On the right side is the right jugular lymphatic trunk. Okay. So what happens? Why does the cystic hygroma develops?
it failures to drain into circulatory system. The sequestration of
So there is sequestration.
yes, sir.
There is sequestration of these lymph sacs, which leads to formation of this hygroma.
Yes, sir.
Is cystic a benign condition? Is it or is it malignant?
Yes, sir. So it is benign condition.
So can we call cystic hygroma as lymphangioma?
Sir,
Are they
actually,
synonymous?
no, sir, they are not.
There is some controversy, but most of the time it is accepted that cystic hygroma and lymphangiomas are synonymous because features are same. Once a lymphangioma becomes malignant, we call it lymphangiosarcoma. Okay, until and unless we call it lymphangiosarcoma, so that is
can call it
synonymous. We call the same. Okay. What are the different microscopical features? You have said pathogenesis. How it differs in microscopy? If we look at the pathology, what are the different types? It may be macrocystic, or it may be microcystic, or combined. Okay. So if the major portion of the cysts are small in size, and usually that affects the adjacent structure, particularly the muscles, larynx, pharynx, then it is microcystic. Within the larynx, pharynx, muscles, most of the time it is microcystic. But which are in the subcutaneous tissue are usually macrocystic, or that may be combination of both microcystic and macrocystic. Okay. Then, so this case you have diagnosed as cystic hygroma by its typical position, appearance, age of appearance, by clinical examination. That is, major portion of the swelling is superficial to the sternocleidomastoid. It has no extension into the oral cavity. Okay, and no obvious pressure symptom. And clinically, it is non-infective. So it is these are your findings. Now, how to proceed for management?
First, I'll go for some imaging. I'll go for ultrasound.
What will be the findings in ultrasound?
Sir, there will be cystic lesion in the neck, and it will tell that whether it is adhered with the deeper structures or penetrating deeper structures or not.
Actually, what are the clinical findings? You should corroborate all these in the ultrasound finding, and you may find little extra in the ultrasound. What was not obvious in your clinical examination, particularly regarding its extension, will be obvious in the ultrasound examination, so that you can plan what may be the difficulty in your management. So suppose this, now you may revise the size of the swelling. You will keep it as 6 centimeter by 4 centimeter, or make it little less for your discussion.
Sir, I'll try to make it less.
Less. How much you like to make it? How much you like to make it for discussion? 4 centimeter, 2 centimeter?
4 by 2, yes, sir.
4 by 2. Okay. So if it is 4 centimeter by 2 centimeter in the left submandibular region, uncomplicated, what will you do? With ultrasound, an ultrasound we have done, that is localized with little extension into the muscle, and the vessels are far away from the swelling. There is a gap between the cystic swelling and the, what are the vessels you should look for its relation? Sir, what are the structures you look for in this region? Is relation with the cystic swelling?
Sir, the common carotid and along with its bifurcation and external and internal carotid arteries and jugular vein both internal and external tubular
As well as other than the vessel, what structures relation you should
nerves.
look for?
Sir,
Other than the vessel, you should look for the relation of the swelling with that important structure, because that may disturb if you plan any surgical excision.
sir, is there any invasion to the distant structure, and is there any nerve? The nerve is involved.
Nerve, it is very difficult to understand by ultrasound. But any other gross infiltration to any other important structure in this region? This region is, what region is this? This region is known as?
Anterior
This
triangle.
region is anterior triangle of the neck, not this suprahyoid. Submandibular region, you are telling. So
Yes,
which gland is there?
Sir, definitely, sir. Submandibular gland.
So will you not look for the
Yeah,
relation
definitely,
whether
sir. Is there any
swelling
involvement of?
the submandibular gland or not? So
Yes, sir.
you may have to excise the submandibular gland during the operation. Okay.
Yes, sir.
Okay. So you have seen that the gland is free, the vessels are free, and the swelling is present, and it is slowly increasing or remaining static. Will you plan the treatment immediately after finding the swelling?
Yes, sir.
Will you plan the?
Not delay.
Hmm?
Sir, I'll go for some basic routine investigations. If they are all normal, then I'll plan for excision.
What is the normal history of this swelling? If you do not treat, what may happen? Suppose you have not intervened. Anyway, you have just done up to the imaging, and then you have done nothing. What may happen to this swelling?
The swelling may develop further. It may get infected and abscess. It turn into abscess, and then may lead to septicemia, and even may cause death of the patient.
Okay, that is one event. What other events may happen?
Yes, sir. But, it will gradually enlarge in size.
Actually enlarge in size. Any other fate? There is no infection, no enlargement, sudden enlargement. We have already discussed.
Yes, sir.
There may be hemorrhage. Okay.
Yes, sir. There may be.
Sudden enlargement. Okay. Or another fate, another more better fate.
Sir.
Nothing has happened, no change in the swelling. It remaining static for months and years. That may also happen. There may not be any progress in the size of the swelling. Okay. Suppose
Yes,
there is no progress in the swelling for months or years. One fate. Another is there is showing recurrent infection. Suppose there is recurrent infection. Recurrent infection without any respiratory distress. Recurrent mild infection. Both way it may happen. Suppose there is recurrent mild infection. What will be your strategy?
sir. First we'll treat the patient with antibiotics, and will take the will make infection. I'll take control of infection.
Then
if it is developing recurrently, then we'll have to excise.
recurrence, it is swelling is there. No question of recurrence. Either it enlarges or remains static, same size, or reduces. What may happen after infection?
After infection, it may decrease in size.
Yes, it may decrease in size, or it may remain in the same size as it was. Okay, or after some time, as by its routine nature, it may progress. So you have to observe what happens. Suppose it decreases after a mild infection and treatment with antibiotic. What will be the strategy?
Wait and watch.
Yes, you can wait and watch. Every milder infection can cause reduction in the size. And after certain age, the cystic hygroma will not progress. Okay, so you can wait. Because operation for cystic hygroma is not always safe. Okay, suppose it is progressing rapidly. Okay, with recurrent hemorrhage or recurrent infection, or by its nature, it is progressing rapidly. So what will be in rapidly we have observed for months, it is increasing rapidly. So what should be your strategy? Quick, you have 10 minutes left only.
Yes, sir.
Then you have to plan some form of
Surgery.
excision, surgery. Okay. So surgery, what do you mean? What type of surgery you will do? After control of
Sir,
infection, you should do
It's
excision.
excision of
What will be your strategy in the excision?
the
Total excision.
complete excision. Total excision, yes, sir.
So during total excision, planning total excision always wanted. But is it possible always to do the total excision?
Sir,
Or it is
not
not
always
possible
possible.
to do total excision? Because if it infiltrates into the carotid sheath, if it infiltrates into the trachea, larynx, then will you go for total excision? Is it possible? Is it
No, sir,
possible to,
in that case, it is not
is it
possible.
prudent to do laryngectomy or
No,
tracheectomy,
sir.
or excision of blood vessel and replacement for operation for cystic hygroma? Not. So always the surgery should be conservative. Right? Surgery is should be protective also to the vital structures. Never do the total excision at the cost of removal
Vital
of the
structure.
vital structure. Okay.
Yes, sir.
Suppose
Yes.
you at operation you are sure that you are leaving behind some portion of the cystic hygroma. Okay. And you have
Yes, sir.
excised the major portion. Then next strategy. Do you understand my question, Shubham?
Yes, sir. I got you. I got you. I got
So you
you.
have rightly done. Post-operative period is good. There is patient has done well in the post-operative period. What are the things you
Will-
do in the post-operative period that you have done a perfect surgery, a good surgery? What are the criteria for a good surgery following cystic hygroma in this particular region? In this particular region,
Sir, functions of
yes.
the nerves are preserved and the gland usually, sir.
Particularly the nerves. Okay, you're right. That is, the nerves are not injured. Cervical branches of the facial nerve, which is supplying the platysma and the muscles of the lower part of the face, are not injured. There is no drooping of the angle of the mouth, etc., etc. Okay, okay. So so perfectly the nerves is preserved. The swelling size has reduced. There is no apparent swelling, but you are sure there is some left behind.
Some tissue left.
Also,
Sir, there will be recurrence. Sir.
recurrence.
I'll
What will you do?
yes. Sir, for that, we can go for sclerotherapy. Like, can it?
Radiotherapy is for a child.
No, sir. Sclerotherapy, sir.
Sclerotherapy.
Sclerotherapy.
So if there is recurrence, there are multiple small cysts. If the recurrence is significant, then you can go for sclerotherapy. Otherwise, you can wait. As in the first case, we discussed that in many of the cases, we can wait. In children, the milder infection may cause fibrosis and disappearance of the swelling that may not progress. But if the recurrence is in the form of another significant swelling, you can go for sclerotherapy. Will you go for surgery again for the recurrence? As a first choice, you will prefer surgery
No,
or
sir.
sclerotherapy?
Surgery will be not first choice.
Because next time if you go for surgery, it will be very, very difficult because of the already depth of fibrosis. So sclerotherapy. What are the agents which are used for sclerotherapy?
Dr. Maiti, can Shubham say is sclerotherapy maybe a primary mode of treatment?
No, I'm coming later. So
Yeah, okay.
this case needed operation. Some cases may not need operation. In that case, we will discuss. The third option. First option is wait and watch, doing nothing. Second option is surgery, and then cure is okay. Recurrence, you go for sclerotherapy. What is the sclerotherapy you use?
Sir, previously boiling water, Sir, previously boiling water was
okay. Okay, Shubham. For your better answer, you say there are many sclerotherapy agents, but the best option is, you say you know it, the best option is, which is being used widely and almost only that agent is used, nothing else. What is that?
Inactivated mycobacterium.
No, bleomycin. Okay.
Bleomycin.
Bleomycin is the most preferred sclerotherapeutic agent for cystic hygroma. Okay. Other options before bleomycin has been used in 90s. Before that, there are many sclerosing agents like boiling water. What are the other agents which are used, which were used?
There is one inactivated mycobacteria, its name is Q something.
OK 432, that is one agent. OK 432, that is being
OK
used also preferably by some surgeons now. So two agents are commonly used, bleomycin, another is
Bleomycin and OK
432.
432.
432 is not usually available in our country, and that is also very costly. That is to be imported from the other countries. And other agents are also the hemangioma, which is used in hemangioma as a sclerosing agent. That is sodium tetradecyl sulfate. That is sometimes also used as cetrol, marketed as cetrol, and sometimes doxycycline. Okay, so that is the agent, and you may need the sclerotherapy more than once. If there is recurrence, you can use the sclerotherapy as a repeated procedure to have the control of the recurrence. Now coming to a swelling which is persisting for long time without any significant enlargement, without causing any distress, without causing any recurrent infection. Will you try for anything?
Yes, sir. In this case, we can go for sclerotherapy as a primary treatment.
Primary treatment. Okay. So in that case, you can, so before sclerotherapy, you can assess the swelling, how the sclerotherapy will be effective or not. What finding you will look for in the ultrasonography for a better result in sclerotherapy?
Sir, whether if it is unilocular, then it will be better.
Better result. So if it is a unilocular or intercommunicating locally, then the sclerotherapy will give a good result if you do the sclerotherapy after aspiration. So when the swelling disappears significantly after aspiration, and if you do the sclerotherapy with bleomycin, the result is excellent. Result is really excellent. Many cases disappear, and the sclerotherapy is many a times is repeated. How many times you can repeat the sclerotherapy?
Sir, 2 to 3 times.
Yes, even more than that, you can repeat. And what is the complication with injection?
Sir, if injection goes to the peri-cystic area, then it can lead to inflammation of the adjacent structures.
Okay, so that is the local
damage.
What is the systemic complication of bleomycin? That you should know in treatment of any malignant disease. Bleomycin is a cancer chemotherapy.
Anti-cancer drug. Yes.
Any pulmonary effect? Pulmonary
fibrosis.
Okay, pulmonary fibrosis. So when you are treating the patient with bleomycin, you should properly examine the respiratory system and also the hematology for WBC count, platelet count, total your breathing time, clotting time, etc. Okay, so patients should be properly monitored when you are giving bleomycin. Okay, so suppose there is a hemangioma. Can it be associated with hemangioma?
Yes, sir, it can be associated.
So there are many case reports. Even I have seen few cases where lymphangioma and hemangioma remain side by side. Those cases, you may better choice is sclerosing agent if you choose, that may be sodium tetradecyl sulfate or bleomycin and sodium tetradecyl sulfate cetrol alternatively. Okay, both of them are good. Dr. Makhullar, ask you a question.
Yes. We have covered almost.
Now,
it can hygroma be diagnosed in antenatal period?
Yes, sir.
How?
Sir, with ultrasonography.
Yes. Some cystic hygroma may appear before birth also.
Yes, that should be. So prenatal diagnosis. So as mainly every pregnant woman is scrutinized or examined by ultrasonography. So if there is a significant size cystic hygroma in the fetus, then that you can diagnose at 10 weeks of intrauterine life. So that should be recorded, and you should note whether the swelling is progressively increasing or not. And also you can have a raised alpha fetoprotein in the amniotic fluid study, and the patient may have hydramnios and if the patient has significant cystic hygroma, then the baby's birth should be always in a tertiary center where the facility of multi-specialty management will be available. So even after birth, some child may need respiratory support. Okay, so that should be taken care of. And do you know, Shubham, the relation of cystic hygroma and Turner syndrome? There is a question for if you can answer, I'll be happy. Cystic hygroma and Turner syndrome. What are the features of Turner syndrome?
The flat chest.
Is there any important feature in the neck in case of Turner syndrome? One important feature in the neck, important clinical findings in the neck in cases of Turner syndrome.
Short neck.
Huh?
The
That's
short
I'm
neck.
answering. That is waves, ridges, waves. That will be unilateral and most of the time bilateral, lateral waves. Okay. So some clinician or embryologist relate cystic hygroma with Turner syndrome finding. What is that?
These waves in the neck.
How it is related with cystic hygroma? It is said that some of the, as we have discussed, cystic hygroma is sometimes self-limiting. It's sometimes resolute, spontaneously with recurrent infection, mild infection, or even it may disappear. Those others believe that it never disappear, according to some. But some embryologists or clinicians believe that during embryonic life, cystic hygromas in the neck gradually resolute, and that is represented in the neck in the form of wave in the neck in Turner syndrome. Those things are correlated, but it is not proved in all cases that whether it is due to this resolution of cystic hygroma. Just remember that the waves in the Turner syndrome is dated
Are correlated with cystic hygroma, intrauterine
hygroma in the posterior triangle of the neck. Okay, so these are the things. So anything else? Any question from the students, participating students, or I don't know whether Monju is there. Any comment?
No comment in the chat box. We have discussed the basic part. You see, the clinical part is important, Shubham. You should give a short case type. But in DNB, there is no short case. Everything is taken as a case. So in that case, one should be giving a good presentation. As I said, a 6 centimeter lump in a 1-year-old boy will be occupying the whole of the neck almost. So you should be clearly defining the extent of the swelling. And the other part, you see clearly that transluminant and fluctuant. Okay, Madam Mighty, then
yes.
Thank you.
Wait.
Thank you. You are coming tomorrow for the conference. I'll be going on Sunday.
তুমি থাকছো?
I'll go on Sunday.
সান্না আমি গেলে কালকেই যাব, কিন্তু জানি না যেতে পারবো কিনা। চেষ্টা করার খুব ইচ্ছা ছিল যে যাব। I'll try. Okay. Thank you, Suho, and all the participants joining in today's program. Thank you, Makulal.
Thank you.